Welcome in, everyone. Thank you so much for joining us for February's Wellness Wednesday. My name is Kiana Hatfield, and I am the program director here at the Parkinson Association of the Carolinas. And today we have Dr. Kathleen Lawrence. She's a physical therapist at Power Back Rehab, and she will be talking to you all today about dizziness and PD. Just a few housekeeping things before we get started. We will have a Q&A session at the end of today's session. So if you have any questions, feel free to place it in the chat box as a parking lot, and we will get those questions answered at the end. And also, if you haven't already noticed, today's session is being recorded. So if you miss anything today or want to just watch the session over again, it will be later available on our YouTube page. But without further ado, I'd like to pass it over here to Kathy.
Hey everyone, thank you for attending. So I actually saw some familiar names on the list, but for those who don't know me, I'm Kathleen Lawrence. I'm a physical therapist. Been a physical therapist now going on many, many years. I'm originally from Wisconsin, so I graduated from the University of Wisconsin at Madison is where I got my physical therapy degree. Started specializing in Parkinson's 3 years ago and have my Parkinson's certifications for LSB, T-BAG, and Power Moves. I work for Power Back Rehab, and we have an outpatient clinic here in Charlotte, and we also do in-home therapy as well. And that is my fun picture of my family. Have to put something cute in there. So these are my objectives for today. I want you guys to learn about the different types and symptoms related to dizziness, how it relates to with when you have Parkinson's, and then find out some things that you can do yourself to help with dizziness. So what is dizziness? It's a lot of things, and it's described in many, many different ways. So we hear things like the room is spinning. We hear people say that they feel like they're on a boat. Some people just say it feels like I have no balance, or that their body's moving in like a circular motion, like they're kind of going like this, even when they're not. And some people will have lightheadedness that they'll call dizziness. But overall, it's generally a feeling that you're going to lose your balance. And then it just comes with kind of different descriptors because it comes from different reasons. So it needs to be addressed because it increases your fall risk. So how does it relate to having Parkinson's? So based on my experience, just my experience, I would say 50% of my patients have some sort of complaint of dizziness when I do their evaluation, and they all describe it differently. So a lot of the causes for dizziness and Parkinson's are actually secondary issues that are related to the disease, or they're related to aging, where people with Parkinson's may be more susceptible to the aging process. There are some direct correlations to Parkinson's. They're very hard to explain, and there's very little research revolving around it, but we'll talk a little more about that. And then what's most important is you do have to find the cause of the dizziness so that you can treat it properly. So these are generally some causes of dizziness. On the left-hand side with the asterisks, those are really what we're going to talk about today, very highly correlated with Parkinson's, but you'll see that there are other causes of dizziness as well. And I want to focus, though, kind of on the ones that are left. So benign paroxysmal positional vertigo, BPPV is the easier way to say that. Inner ear disorders, vestibular impairments, orthostatic hypotension, medication side effects, and of course, just neurologic disorder in general. So these are some risk factors that really are common in Parkinson's that even make you more at risk for having dizziness. So orthostatic hypotension we'll talk about a lot, highly correlated with Parkinson's. It's correlated with autonomic dysfunction, or it can be a side effect of taking your medication, the carbidopa-levodopa. Rigidity, also a common Parkinson's symptom. It limits your upper body movements and neck movements. and that can lead to vestibular issues. A fear of falling just in itself can be a risk factor for dizziness because you start exhibiting some self-limiting behaviors, and these self-limiting behaviors then lead to vestibular issues. If dyskinesias or dystonias are part of your Parkinson's symptoms, these can cause confusion in the inner ear and vestibular system. And then, of course, Parkinson's is a brain condition. And I would say the biggest issue is that there's oculomotor dysfunction, which is issues with the eyes. And we'll talk a little more about that as well. These are just some additional factors that happen when people have Parkinson's. Of course, most folks who have Parkinson's are being diagnosed in their senior years. So there are some age-related changes that might be happening that is just coincidental with the fact that you have Parkinson's. Just because you have Parkinson's doesn't mean you don't have anything else like arthritis in your neck. Your vestibular system can just naturally deteriorate with age. You could have any cervical degeneration in the neck that limits the range of motion of your neck. And then we notice when people have Parkinson's that a lot of times they have very self-limiting behaviors. And these are some of the behaviors that we've kind of seen in physical therapy. People will avoid turning. They just won't do it. They go straight forward. If they're turning, it's a very slow, cautious turn. They avoid putting their head in like a downward position. They don't turn their head, either because their neck is rigid, or they are actually fearful that if they turn their head quickly, that they're going to have a symptom of dizziness. And then this causes a bad circle of not moving your head at all, and then just reduced mobility too. So people who used to be really active and really stimulating the vestibular system, sometimes when you have that Parkinson's, you start self-limiting. You're not going out as much as you were before, and then just naturally your vestibular system will decline. But these are my big four when it comes to Parkinson's: the BPPV, vestibular dysfunction, orthostatic hypotension, and medications. These are the ones that are, in my opinion, are most correlated to the having Parkinson's. And we'll go through each one and we'll kind of tell you what they are and then kind of how it relates to Parkinson's. So BPPV, and I put BBPV, sorry. This is the most common form of vertigo. And this is literally, people are saying the room is spinning. So this is vertigo, that spinning feeling. And this is characterized by these brief episodes of spinning sensation that occur when you're changing your head position. So most often it's when you are lying down and you're going up to sitting. But it also gets very confused with orthostatic hypotension, which we'll talk about. That is more of a feeling of lightheadedness. It's always trying to get people to distinguish, is the room spinning or do you feel lightheaded? Those are important symptoms that we use to distinguish the root cause. But this can also happen with head turns. If you just turn your head quickly, especially horizontally, you can get vertigo. And it's really a displacement of the otoconia, very fancy word, with just the crystals that are inside your ears. So we have these semicircular canals that are in our ear that help us with our balance, and they can get into the wrong canals or they can get stuck in different places. And when they are displaced, then you're getting the wrong message. They're overstimulating in one part of the ear, one side sometimes versus the other, and it gives you that room is spinning type of feeling. Now it can be fixed with repositioning maneuvers, and you want to have this done by a vestibular PT or ENT. The correlation to Parkinson's is not quite understood, but it may be due to reduced mobility and rigidity in the neck makes people more susceptible to this happening to them. So a lot of people that I work with will report maybe that they sleep really still at night in one position, and they're in that position all night, and then they try to get up and boom, the room starts spinning, versus maybe somebody who is kind of rolling side to side throughout the night, might have it less. Or if you're a heavy side sleeper just to one side, you could then have more of a risk on that side for the crystals to be displaced. And then just not being able to move the head. If you have neck rigidity, if you have any dystonias, you're going to be more at risk for this as well. The next one is vestibular dysfunction. So this is an impairment of the vestibular system, which I mentioned was in the inner ear. The vestibular system helps you maintain your balance. It's really important. It helps with spatial orientation. So where is your body in space? And it also impacts coordinating eye movements, which we've seen in Parkinson's is really a cause for concern. There are a number of other causes for vestibular dysfunction. I've listed them there for you. Because again, just because you have Parkinson's doesn't mean it's 100% related to Parkinson's. It could be any of these other conditions as well. But we'll talk specifically about what is happening with people who have Parkinson's. So there is some conclusive evidence for vestibular dysfunction in Parkinson's, but it's been really slow to come out and to be researched. And, those of us who work with people who have Parkinson's, we see it all the time. We see it every day. We know it's there. But there's just not a lot of research out there that is giving us a lot of information on that kind of root cause. But there's definitely been found to have some neuropathological changes in specifically the vestibular nuclear complex in the inner ear. And then another fancy word with the purposive hypoglossy, which is actually, it controls our eyes and then the root of the vestibular nerves too. So everything in our brain is really, really connected. So it makes sense that when you have any type of neurologic condition, that other parts of the brain might be impacted as well. And there's just really this integration between our eyes and our ears is what is abnormal in Parkinson's. And this is what causes a lot of these complaints of dizziness. We see a lot of vestibular hypofunction, we call it, and that's when both of the ears are not functioning the same. So one side is not being as strong as the other, and some people might even say they feel a pull to one side or the other, and that's just coming from the inner ear, not giving equal signals from both sides. And then we do see a lot of loss of our vestibular ocular reflex, which is when you turn your head, what your eyes do. So there is a big correlation between eyes and ears, and oculomotor dysfunction is very prevalent with people with Parkinson's, and I don't think that it is a big focus for a lot of doctors or even therapists. And even our clinic, we're still trying to, identify this correlation between how our eyes are moving and what that is doing in terms of dizziness and what it is doing in terms of our balance. So there's still a lot to be learned in this area. The good news is that the vestibular system can be treated, and it can get better and it can get stronger. So orthostatic hypotension is probably the most common thing that anybody on this presentation has probably heard of because it is very prevalent. And this is when you have that sudden drop in blood pressure upon standing up or going from lying to standing. And this is described as dizziness. People say they're dizzy. They could even have vestibular issues, like their eyes are not focusing, or they can't control their eyes, or lightheadedness is the true symptom that usually is just described in different ways. So doctors define orthostatic hypotension as a drop of greater than 20 on the systolic blood pressure, which is the top reading, and then, or a drop of 10 on the lower, the diastolic, within 3 minutes of standing up from sitting down or lying down. So this can be a medication side effect or an autonomic dysfunction. So autonomic dysfunction correlates highly with Parkinson's and any of the atypical Parkinson's, your MSA, PSP type of diagnoses. So when orthostatic hypotension is a result of the neurologic condition, we actually call it neurogenic orthostatic hypotension. So this is just a subtype of orthostatic hypotension when people have this impaired regulation of standing blood pressure due to autonomic dysfunction. So our autonomic system, if that's an unfamiliar term, is the part of our body that controls things that should just happen naturally without thought. So that's your blood pressure, that's your heart rate, some of the bowel controls, those things fall under this kind of autonomic. So think about anything in your body that's supposed to be automatic, and it's probably controlled by the autonomic system. And when you have a neurologic disorder, you're highly at risk for having autonomic dysfunction as well. And this is when the nervous system is not able to make or release neuroepinephrine, which is this chemical that constricts blood vessels and helps raise blood pressure when you stand up. So when you stand up, basically all the blood that's in your abdomen wants to go down to your legs. Gravity can be our friend, but it can also be our foe. So in this case, it's our foe because it's pulling that blood down and the body's not responding fast enough to constrict the blood vessels to keep the blood going up to the brain. And that's when the blood pressure drops and you feel lightheaded or dizzy, however it feels to you. And this is really most common with our MSA diagnosis, which is an atypical Parkinson's. It affects 75%. But it is also very common with Parkinson's, where 58% of people with Parkinson's will have this type of orthostatic hypotension. Much higher percentage if you're combining all of the orthostatic hypotensions together. And this distinguishing factor for determining whether you have the neurogenic orthostatic hypotension or you have just regular orthostatic hypotension is what happens with the heart rate. So if you have a blunted rise in your heart rate, that is indicative that it is a neurogenic orthostatic hypotension. So I've read different viewpoints. Some people say the heart rate should rise 15 beats per minute if the blood pressure drops. Some people say 20. So little disagreement on how high the heart rate should increase with a traditional orthostatic hypotension. But if you had a traditional orthostatic hypotension, you could think that that may be medication related or that it is dehydration. So we see that a lot, that people are just having that low blood pressure because they're really not drinking enough water. That's an easy fix when that's the case. When you have the neurogenic orthostatic hypotension, you do have to do some behavioral changes. And I have a whole slide for that because it's so important. All right, so medications, carbidopa, levodopa, orthostatic hypotension is a big side effect of that medication. So it will cause dizziness. It does not with everybody. And it's sometimes hard to tell. And sometimes dosing is important for how that how people react as well. So lots of different things can happen just with that medication that is so critical for people who have Parkinson's. But also, you have people have other conditions as well. Depression, you may have some dementia or anxiety. And those medications that are used to treat those conditions also can cause dizziness. So you may be on a medication that's causing dizziness, and maybe we're saying that it's Parkinson's, or maybe we're saying it's a Parkinson's medication when it may in fact be one of the other medications causing dizziness. So this is a great conversation to have with your physician. So what can you do? This is the most important part. I want to make sure I'm on time. So if you have BPPV, I don't know why, I think it autocorrects, sorry. You have to find a vestibular PT. So when you have positional vertigo, and your symptoms would be, you're lying down, you're sitting up, the room is spinning. Okay, that's vertigo. You can get that treated even in a couple sessions sometimes with a physical therapist who really knows what they're doing. So there's a lot of different canals. So I know a lot of people will just go on YouTube, and the Epley maneuver is the most common maneuver for that. And so I know people will go on there and, and try to do their own Epley maneuver. Sometimes it works, sometimes it doesn't. And the reason is because the Epley maneuver is just for one specific canal. So if you have, there's 3 canals. So it's really important to find a physical therapist who knows what they're doing, who's going to test all 3 canals and then provide you with the correct repositioning movements to get those crystals back in place. That is really your best bet for getting rid of the vertigo. Now, sometimes it goes away all by itself, just because maybe you slept through the night again and the crystals went back where they were supposed to. And that's great when that happens. We've found also there is no research to support what I'm saying, but we have just found that people who are chronically dehydrated are at higher risk for getting this. And in the many places I've worked, when we've told people to drink more water and they've actually followed through, they would have less chance of this reoccurring. Because unfortunately, if you get it once, there's a good chance that you'll get it again in the future. It just means you're more at risk for it. Orthostatic hypotension, I have a slide on behavioral management, so we'll talk about that next. Medications, you're going to have to talk to your physician about medications and what might be causing dizziness. And then vestibular dysfunction. So you want to find somebody who's really good with vestibular. If you call clinics, you're asking to see their vestibular PT. And they're going to do a really thorough assessment to figure out precisely why you're getting these vestibular problems. And they'll do a really good vestibular test. You can also, ENTs also can test, and they do real fancy tests as well for these types of dizziness. And a lot of times that's really helpful for when the PT's treating. But we usually like to try to figure out what is the root cause. Is it really a cervical issue? We have definitely found that when we work on someone's neck, And we provide manual therapy to their neck and provide more range of motion in their neck that people's vestibular systems do improve. If we find really that the issue is the eyes, that the eyes and the ears are not doing what they're supposed to do, we have exercises to train the eyes. So yes, you can have eye exercises. You have to exercise your eyes too. And habituation exercises, gaze stabilization exercises are all different types of treatment that you can receive if your dizziness is caused by the vestibular system. So we highly recommend seeing a physical therapist. If you do have neck rigidity or any loss of range of motion in your neck, we do recommend some myofascial work or some massage therapy as well for that. There is one type, before I go on to the behavioral modifications, there is one type of dizziness that is very confusing still to doctors, to physical therapists. And I would say maybe 1 out of 10 of my patients will report just the fact that when they're standing, they don't feel balanced. They could be standing as still as they could possibly be, not moving at all. And they could tell me that they feel like they could fall at any minute. When people start having those type of complaints, they call it dizziness, even though it's more of a unsteadiness that they're feeling. A lot of times that is just the sensory motor issues with Parkinson's. So the message that the body is telling you about your position in space is not accurate. It's just very similar to some of the other types of Parkinson's symptoms that you may have, that you speak softly and you don't think you speak softly, but everyone around you tells you you speak softly, or that you walk small, or you move slow, and you can't have that. The body's not telling you the right message. It's kind of in that same realm where it's a miscommunication. And we have results with really treating people's balance statically and dynamically to make people feel more confident. But we have not seen a lot of success with that particular type of dizziness actually going away and people having the right message. Nobody has quite figured that out yet. It is kind of a rare type of dizziness with Parkinson's, but that is our most challenging when someone describes their dizziness like that. So the behavioral modifications for orthostatic hypotension, this is so critical that you can take your own steps to help. So some of the lifestyle modifications is adequate hydration. Of course, this is a recommendation off the internet. Everybody is kind of a little bit different. General rule of thumb, half of your body weight in fluid ounces is what you should be intaking every day. If you have low blood pressure, they have found that bolus drinking will increase blood pressure pretty quick. And we find this, we do this in the clinic quite frequently. And the theory behind it is when you drink water really fast, that it triggers our sympathetic nervous system, which is our fight or flight system, to turn on. And when that system turns on, it increases your blood pressure. So we can have people come into our clinic, very low blood pressure, have them drink very quickly, not like chugging, but drinking quickly. 2 glasses of water, maybe 5 to 8 ounces, and their blood pressure can increase by 10 to 20 systolic, and their blood pressure then will remain, I'm going to say high, for lack of a better term, high during a therapy session. So that's a little trick, if you have low blood pressure, how to try to get it up quickly so that you can be safe. A lot of people swear by salt intake, but this is very important for you to speak to your doctor about appropriate salt intake. But I did literally have a woman whose prescription was to eat bacon every morning so that her blood pressure would go up. And that was approved by her doctor, and she did very well with that. And she greatly enjoyed that intervention. For some people, if you actually have high blood pressure while you're sleeping, if you tilt your head up a little bit, so it says like maybe 6 to 9 inches, it's not that much, that will help to have that, so you don't have that initial drop when you sit up. Conditioning. So if you're in good condition physically, you will have less issues with blood pressure. It's not a be all end all, but just generally speaking. And then an interesting fact is that 60% of people that have this orthostatic hypotension have these symptoms within 2 hours of eating a high carb meal. So we found that to be really interesting as well. And I've definitely read that the carb meals can have that effect on blood pressure by lowering it. Some people might want that. In our case, we don't. And then, of course, hot weather, hot showers, baths will lower blood pressure. And then, of course, if you really are having issues, there's these physical counter pressure maneuvers that you can do. So if you stand up and you start feeling that something's coming on, you can do things like cross your legs, squat, tiptoe, anything really that causes the lower extremity muscles to contract will help keep the blood push back up into the abdominal cavity, which is the issue. And then, of course, what's not on here is that you could wear compression stockings or an abdominal binder as well. People don't like those interventions, but they do work well for people that maybe have a harder time with behavioral modifications. That becomes a good modification for that. And that will reduce your feelings of dizziness and lightheadedness with standing. So that was kind of it, the presentation. I was telling her before the presentation that really this is complex. We could probably have a good hour conversation about this and really even just vestibular. I can do an hour just on vestibular because it's so complex, and especially complex with neurologic conditions. But I'm open for any questions that you guys might have.
I have one.
Mr. Smith.
I have
Hi.
experienced what you've talked about in terms of the benefit of water. I don't tend to drink enough, and when I do, I get much better results at the gym in terms of working out.
Yeah.
But I also have an enlarged prostate, so I'm dealing with another issue. And the more water I drink, the more time I spend in the bathroom. So how do you find that? The way I balance that out is I don't drink as much water as I probably should. So
Yeah,
can
so part of the issue is figuring out what's worse.
okay.
Is it worse to go to the bathroom a lot, or is it worse to be dehydrated and have, poor performance with your workouts? And I would say you could probably play it day by day too.
Yeah.
If you had a day where you're like, okay, I'm going to be out and about and I cannot, go to the bathroom every hour, that would be an inconvenience. then obviously you would take that into consideration. But if you have access to a bathroom, going to the bathroom more often during the day is not a terrible thing. It just becomes an inconvenience.
Right.
And which I understand is a big inconvenience.
Well, that's helpful. Thank you.
Yeah. Sorry.
All right. Our next question, Ms. Kiss.
Yes. So I have a question about the carb meal causing symptoms. When the instructions on carbidopa levodopa is don't eat it with protein.
I know. It's very complex, isn't it? So some doctors don't tell that to their patients. And the doctor that I work with in their office has really not given their patients that advice with taking it. But I know that is something that's out there, and there are other doctors who say not to eat it with high protein. So I think it's really the high protein though, where if you are having, I don't know, say a breakfast where you're eating, 3 eggs, and that's a lot of protein. That maybe if you took the carbidopa with 3 eggs, your body would be fighting to absorb the carbidopa, which is the argument with the protein, is that your body will absorb protein first. Sometimes they even just say, take it before your meal if you don't have nausea. They'll say take it before your meal, and then you can eat, whatever you want after that point, because the absorption has already started. I think really the answer is that everything has to be balanced. Don't have too much protein, don't have too much carb, balance it out nicely, and then see how your body reacts. And I don't think that everybody will have a drop just because they had a high carbohydrate meal. So it might be something that you would want to test. So, you could take your blood pressure, before you eat, have a delicious bowl of oatmeal, which we know is super high carb, and then test your blood pressure for the next 2 hours and see if you are somebody that has that experience. Not all of my patients have that experience, but some definitely do. Some can very much verbalize to me that they had a carb. They stood up after their meal and passed out. So some people, it's like everything, right? Everything is individual to you. So, you could just test yourself and see if you're one of those people. And if you're not, then you can just be happy and eat whatever you like. Or if this is an issue, you'll know to be more cautious.
Thank you. Just to clarify, my husband's doctor did not mention this at all. We just read the fine print that comes from the pharmacy each month.
Yes. I don't think doctors really buy into it that much, from what I understand. But I think, every doctor has their own personal opinion, and I think it'd be great for you to ask at your next appointment.
Thank you.
Yeah.
Do we have another question?
I'm sorry, I might also add, we live in Winston-Salem, and my husband actually did vestibular therapy. And it was the best therapist we've ever worked with. So I don't know if anyone else is in this area, but it was Select PT in Winston-Salem. So if anyone's in this area and looking for a vestibular therapist, I would just throw that out there.
Oh, that's great to hear. I love hearing stuff.
Thank you for that. Do we have any other questions? And feel free to unmute yourself if you do. Not seeing anything in the chat box.
Okay.
I guess maybe while we wait for another question. So if you didn't catch Kathy's information, feel free to reach out to me and I can connect you with her. And I would say, Kathy, do you have any like frequently asked questions when it comes to this topic while we wait?
I mean, the biggest thing is if people just want the dizziness to go away. And their question is how can I make this go away? How can I not feel this? And the biggest thing is figuring out exactly what is causing it.
Mm-hmm.
And then you'll know how to treat it. I would say it's really just high, I would say high on the list of complaints and questions when I'm doing my eval. I might do a whole eval and all of a sudden at the end, they'll be like, well, I kind of just always feel dizzy. Like right at the end, they'll throw it out there like it's nothing, but it is a big deal. So, yeah, I would just say try to get it addressed, try to get to the root cause and get it treated so that you can feel better and reduce your fall risk.
Okay, thank you.
You're welcome.
Do we
Thank you,
have any other
everybody, for attending?
Yeah, thank you, everyone. Double checking the chat box. I don't see any other questions, so I think we will go ahead and wrap up today's session. Thank you, everyone who tuned in today, and thank you, Kathy, for taking the time to present to us all on the topic. As a reminder, this session was recorded and will be available on YouTube later this week. But in the meantime, if you have any questions, feel free to reach out to us here at the office. And if you need to reach out to Kathy, either take note of the information here on the screen or we can connect you with her as well. But again, thank you, everyone. I hope you enjoy the rest of your Wednesday.
All right. Thank you. Bye.
Bye.
Thanks, ladies.